Good evening, everyone. And at the outset, I thank the organizers, Dr. Rima and Dr. JP, for giving me an opportunity to share our experience and a part of the SBRT spine program. So I'm going to talk about around 15 minutes immobilization techniques and image guidance for SBRT spine and their impact on the margins. We had already had a very good lectures and the teaching program in SBRT for the spine with various with other speakers, and there may be a little bit of overlap because like a lot of things are overlapping in this. So I'm going to talk about SRS SBRT as a general and immobilization technique that is the key for like success of any SBRT program. And simulation, that is where we usually talk about PET CT, MRI, CT and MRA, and where to do it and when to do it, and what all the plus and minuses. Contouring and planning is also important, and the practical aspects of like my experience with CyberKnife for the SPRT spine. So this is now SRS SBRT. Any radiation oncologist should know, and even the all oncologists and including the patients comes with the terminology called SRS and SBRT. We are talking about a stereotactic guidance with eye accuracy with a short course of treatment, either as a single or a 5 fractions. Whenever we talk about stereotactic radiation or an SBRT, in mind, we need to think in a different way than a conventional radiation oncologist. So we are looking at a target of a small target and the treatment volume. That is what is important, because reducing the volume of normal and target tissues irradiated to higher doses improves the tolerance. Sharply defined target, this is actually practically sometimes we don't give any margins for our any of the SBRT targets. And accurate radiation delivery, that is the key here. So we are not looking for like any microscopic or like the extra doses to the surrounding structures. And eye conformity, this is the important thing, because organs at risk was our one of the main problems in radiation oncologists. We have overcome those problems with eye conformity of our treatment. So, and sensitive structures are excluded from the target. So our once the sensitive structures are excluded, then you are hitting the target to the desired dose. SBRT spine. Now, actually, if you see SBRT, when we started 15 years back, it was very small. It's in a baby steps, like when you say it was in an infant state. Now it has gone to definitely it is taking a shape. The SBRT is important in across all the tumors. Basically, and importantly, the coming years, the epitheliary, prostate, and lung, where the radiation oncologists are lagging behind, is the future. The SBRT spine is one of the things which is already started. We have an experience of more than 20 years, starting from like, the brain and the spine. So when we are talking about this, the important thing we should look at is target size, location of the tumor, proximity to critical structures. That is how you're going to select the patient for SBRT spine. And it also depends on what type of scheduling you are using, clinical protocols, and you want to follow the published guidelines. So what in terms of dosing and the normal structure constraints. And any of the SBRT program, when you are looking at the spine, it has to be multidisciplinary review has to be done. The surgery, medical oncology, and radiation oncology should also be a part of it, and to understand that at what time we can intervene and what time the surgeon should intervene in these cases. So multidisciplinary approach has to be the key word here. And it also depends on delivery of capability of the LS systems, what setups you have. So that is also very, very important. So we are aware of that. These are the LINAC based SRS SPRT, starting from my can call it as my baby, like HCG, like it's CyberKnife and Versa HD or any of the machines on Electra or Variant platform or Radizact. So you can, these are the machines like we are already come across. And the setup has to be good enough to take care of SPRT program. So SBRT flow, if it is not different from any of the other radiation treatment, so the patient selection is the key. We are already talked about that. I believe that the how to select a patient for particular SBRT spine, and immobilization techniques, simulation, target delineation, planning, evaluation, and implementation. Each step is important. I always tell our colleagues and our residents, all the circus has to be before the patients go in onto the treatment, because this is very very short duration. By the time you realize those mistakes are cannot be corrected, because it's a short course of treatment. So you have to be very very put your all effort to in first three or four things: immunization, simulation, and target delineations. If once you do this, then the rest of the things becomes a little bit easy. Coming to immobilization, it's always a challenge. So we this is ideal immobilization versus reality. So we know that we are always like, when you see the CT scans or the images, these are all static images. It is like a dead patient, but the patient is always dynamic. So you need to keep that in mind always. So the any immobilization device, what are the points you should remember is it secures the patient and constrains motions in comfortable position. I would like to highlight here, this comfortable position is the most important thing to keep it in mind. It should not interfere with simulation, treatment, and localization of whenever we are using these things. And it should be easy to use and inexpensive. Definitely, it should be inexpensive, so that is most of the times we use individual for each patient. Dictum is minimalistic approach with a maximal comfort. So that is what I'd say, that like as much as possible, keep the patient in their comfort level, rather than doing anything to tell that they may do one day and the next day they may not do the same thing. So reproducibility is a challenge. The best is to do make them comfort. So these immersion devices also evolved along with the technical evolution. So initially we have used the fixed stereotactic head frames were adapted to become more robust. So we always thought that fixing, particularly for some of the times, it's always good. So I remember when I was in AIMS, like they, even though with the fixator, when you do it, when you take that in a SRT program, when we see for 25 days, there's a lot of difference in terms of the reproducibility is concerned. So nowadays, all major manufacturers provide frameless solutions. That is the one. Putting the frame is always an issue. Reproducibility is an issue. Frame based, like we are all know that we use frame based for basically for upper cervical spine. In spine, when you are talking upper cervical, mid thoracic, and the lower thoracic, and when you are talking about lower lumbar, the lumbar areas. These are the areas where we are mainly concentrating. The frame based, we are aware of that it has its own problems. Frameless is the one what we usually use it nowadays. It may be vac lock, alpha cradle, body fix, or thermoplastic mask. Everything comes with the plus and minuses. I always suggest as less as possible is a comfort to the patient. The vac lock should be good enough to consider always. There are a lot of data to say that there is nowadays even the minimal as much as possible. To the extent there is a the foam, the simple foam based, the bed should be good enough to take care, because we are using image guidance as a priority. So this most commonly we use employing thermoplastic masks were with or without mouth bite. So localization is by the image guidance. That is our priority in these cases. So indexable to couch top or an extensions, it should be most of the times it may be compatible with MRI. So when you see that, like whenever when you see the differences of that, it all comes to between a sub millimeter to 3 millimeter, like 3 to 5 millimeter to the sum of the extents, most of the time in terms of y-axis. So frame-based SBRT. So these challenges we have already talked about it. I don't want to. We all know about it. Anybody starts the SBRT, and I always not very promoter of fixed frame-based SBRTs. So overall, when you take an SBRT for the immobilization, the systematic setup uncertainties should be less than 3 millimeter. So it should not be more than 3 millimeter. These things are very important whenever you are talking about the single lesion, multiple lesions, single fraction. and multifractionations, and also re-radiations. Keeping it in mind, spinal cord is not going does not forget. Actually, whatever the injury is there, you will come to know only after 2 to 5 years sometimes. So you should be very, very careful about in the vertebra, especially with the spinal cord. So sometimes it is indexable for the treatment couch. As I always stress, patient comfort, positional stability, and the reproducibility of the setup is the key in case of any immobilization. What we want to use it. The radiographic markers and other things are as and when required. We'll use it. So in terms of the alpha cradle or the abdominal binders, all those things can be still be used for the all abdominal things can be used for vertebra also. What the spine SBRTs. So keeping it in mind, there is always a chances of longitudinally around less than 3 millimeters should be kept in mind whenever you are considering for your margins. And according to that, if you want to include it as a PTB margin, you should include it. So the immobilization action points equipment should be evaluated for its effectiveness in targeting accuracy and precision. That should be done from your physics side, and thoroughly assess in order to quantify the uncertainties in if it contribute to the delivery of SRS or SBRTs, and should be evaluated for beam attenuation and surface dose characteristics. These are the task group recommendations, and I'm sure that your physicist will consider for all those things. Coming to the simulation is the most exciting of the recent era for especially with the SBRT. So I do all my simulations as to be PET CT and MRI, and with contrast and without contrast. So this is the important thing, and MRI also with contrast, like both with contrast is important. And as and when required, especially with the patients that are already having implants, the cysternography can also be considered in these cases. So to delineate what are your targets, delineate the spinal cord kind of things. So the tolerance of the radiosurgical procedure, as I told you, that slice thickness, there are two important things before, pre and post contrast. Slice thickness I usually do for 1 millimeter to 1.5 millimeter. Ideally, it should be 1.25 millimeters. And it should be around minimum 10 centimeter above and below your targets. If multiple targets are used, you have to keep those things in mind. Like it's at least especially when you are talking about LINAC based, ARC based one, you need to make sure that you take adequate margins in terms of coverage is concerned, because entry and exit dose also should be considered into the plane, especially in non-coplanar. So FOV should be good enough to do calculations for all the things are included. And the MRI wise, both the treatment position is always a challenge. So we have a PET CT simulator, it becomes easy. The PET and CT and the MRI, also we use it in the treatment position as much as possible. And it is definitely difficult, but like the newer softwares are very good to fuse in these cases. So the recommendation is they talk about less than 2 millimeters. I prefer 1 to 2.5, 1 to 1.25 millimeter thickness should be used. And as an MRI should be a part of it. Any SBRT spine, do not do the SBRT without the MRI. So like it gives a lot of information. Sometimes PET CT or CT including your target delineation, MRI will be helpful. Motion management is not a key for in these cases, because with good image guidance of the I don't give importance to the motion management of the in case of respiratory gating and all things. Actually, it may not be required, so we don't use those things. So whenever you're seeing that with image proper immobilization, the CT, MRI, and PET fusion are the one we fuse, and we prefer to do is an axial fields. But in case of MRI spine, and we prefer sagittal or coronal, whenever we start with one, please check it in all the sections and make sure that, especially when you're marking the spinal cord as a separate. So when we are marking, I don't mark the spinal cord, vertebra, the space, the CSF space, all are marked separately. Don't just mark the overall spinal cord, the cord cavity as one of the spinal cord. Mark exactly the spinal cord proper. So this fusion has to be rechecked with the physicist, and all our anything about SBRT, all our radiologists rechecks and make sure that like we are on the same page. And depending on the institutional protocol, you can always make that in terms of which software to fuse. You can use those things. There's a very clear critical contouring guidelines available. I don't want to go detail into that. GTV and CTV are same for me with whatever the available, both PET CT and MRI data. So a GTV is going to be a CTV. If at all, if you want to have a differential dosing systems, that we can call it as a SIB or different doses, you can make it as a 2 different volume. As much as possible, I prefer single volume. So and in terms of PTV, it's either like as I told you that in all LINAC based the SBRT for the spines, the people are giving between 1 to 3 millimeter, minimum 3 millimeter is the margins what they are planning, what they recommend. But I don't practice any of the extra margins as a PTV, because like your imaging guidance is very, very good. The planning evaluation is that's a separate topic. I don't want to go into that. You need to keep those things in mind. All those whenever you're planning and evaluating, your immobilization techniques should also be kept in mind. So whenever this is an arc, like you can see very clearly, you can make a donut distribution. Now the spinal cords are saved and getting less than 20% of the dose to that. And whenever you are giving prescriptions, I usually give between 75 to 85. No dose dumping. I don't believe in that dose dumping. You can have a clear cut doses either in the single fraction versus 5 fractions. But 30, I always look for 50% and 30% of the doses, which definitely should be in the range of 3 to 5 millimeter or 1 centimeter within the targets area. So targets, dose coverage, dose follow-up, these are the plan evaluation. I don't want to go into details into that. These are all to be kept in mind, the overall process when you are done. What is your immobilization techniques, what were used, and according to that, the dose and the plan evaluation has to be done. So these are the action points. From this point, very image registration for individual patients, appropriate technique, and all the normal structures has to be marked like within the area of target of at least 3 to 5 centimeters, where the iDose beams can come into the pictures. So look for the low dose pills, that is radiation. The physicist will help you to check, and all the QA they will get it done. I don't want to go detail into that. And treatment verifications and 3D image based, like in case of CyberKnife, we have a continuous tracking system, and the image based 3D image based is a key in, and you have to make sure that, because with the higher image guidance is using your immobilization should be minimal, and like as much as possible, it should not cause comfort to the level. Nowadays, to the people are telling that as minimal as possible, make the patient's comfort is a key because of your higher image guidance and this short duration of treatment. So this is one. So the quality assurance should be taken care in each step in case of in these patients. Practical aspects for the spine. So my suggestion is like sites. The site of the tumor is most important. The CSF, dura, intervertebral disc, spinal cord, and vertebral body. Please take all these things into considerations. And it also either a primary or a metastatic things. Either is a primary tumor and the metastatic tumor, and your radical versus palliative, single versus multiple fractionations. Recurrent cases. The recurrent cases of SBRT spine is a big numbers. If you see a lot of patients are like, sometimes we cannot treat in a normal way. So this is very, very challenging in these cases. Clinical. So clinically, the patient whenever you're making an immobilization for an the spine, you need to keep it in mind. These patients have a lot of pain. They have to give a very good painkillers to the extent even diuretic patch is not a bad idea, so that your immobilization devices, the patient can lie down comfortably, and also make sure that they have to be sustainably lying down on the same position for a 10 to 15, minimum 15 to 20 minutes. So either it's the image acquisition or it's the treatment. So the spinal cord compression is a contraindication. Some people say that, but I've done around 3-4 patients when it is a spinal cord compression also. But when you're starting as a fresh, so you should be careful about that. And another important thing is SBRT spine is the most. If you want to start any SBRT program, start with the spine vertebra, the palate, the single vertebral metastasis. It gives a more confidence, but in the same time, it is the most detrimental. What I say is because if you don't do it properly, the spinal cord never forgives. So there is there is going to be a lot of issues with the post-treatment complications. So the primary tumors, there is a very established indications. The margins, and especially the in metastatic setups, we know that the IRCC guidelines. So if usually you use one extra level of the things, so that like we are including the particular. There's no need to include the whole of the vertebrae every time. So where we conventionally we have taught, and I've given radiation 2 vertebrae above, 2 vertebrae below, to then 1 vertebra above, 1 vertebra below. So when I show the next one, we see that in the vertebra, whatever is involved, we are treating only that. So PET-CT and MRI is the main important. GTV and CTV, if you want to do it, you can do it, but I don't practice. Is the GTV and CTV are same, but there may be dose variations in the some of the things. PTV 1 to 3 millimeters is recommended. OIRs, especially the spinal cord, has to be marked at least 5 centimeter above and below from your target is the best way to mark it. They dose 18 gray single fractions to 21 gray single fractions. I usually don't practice much of the single fractions. I fractionate. It is the safest, and the spinal cord will always have a respect to the spinal cord. 25 to 35 gray, either it's a 3 to 5 fractions is the one what I usually practice. So we have almost around 12 and a half years and more than 3,500 cases. And now we are having around more than 200 cases of spinal tumors we have done. And just to give some of the example, a single area, like it's with the PET-CT scans, and there's an upper cervical. And if you see that 2 areas, the spinal cord here is 25 into 5, there's almost brushing to the spinal cord. This is another one. So more than 2 area, only vertebral body, and all of the vertebra and soft tissue component along with the vertebra. There's no need to include the other part. And multiple areas can also be treated. So whenever you are treating multiple areas in a LINAC based, please make sure that if if they're in continuous, then only you'll do it. In CyberKnife, even if it's a multiple sites, if there's a gap, sometimes up to 3 to 5 centimeter views, more than 2 vertebrae above, I usually plan independently, because that's it's always better to treat them independently. And multiple areas can be treated. This is some of the primary tumors. This is neurofibroma, then plasmacytoma, and Ewing sarcomas are one of the vertebral Ewing sarcomas are one of the good numbers, chondrosarcomas, and this is intraspinal tumors and ependymoma, long segments, more than 2 to 3 centimeter, more than 3 or 5 centimeter. There's always a challenge, and you can see that if I always say that if there's a 1 millimeter demarcation is there, the dose fall may still be going to around 20 to 30% dose fall can be considered. Multiple neurofibromatosis, intramedullary tumors, and vertebral hemangioma. And these are the drop meds and the dural based, where you can see that the spinal cord is marked very clearly and the dura is marked separately, and cardomas and dural metastasis. And this is another cardoma where we treated. So the SBRT to the spine is, if you want to start any SBRT program, spine is the best one. Start with the palliative and single versus fractions with 5 fractions, and that gives you more confidence. So use the immobilization device which is available with you with if all the attachments is available, you can use it. But to the extent with the experience, I feel that patient comfort is the most important thing, and use the Vaclock is the one what I usually use it, or like maybe the simple foam. So is the one. And depending on the number of sites, also it is important. Time taken is also be important. So, as I told you, immobilization should be simple. Margins, GTV versus PTV. GTV, which is acquired through both PET-CT and MRI, is the one what I'm looking at. And dose 25 to 35 gray is the most one, either is a primary or a secondaries. But as much as possible, these patients will have very good pain control. And I've seen in oligometastatic setup, there is definitely a survival advantage of these cases. And I am in terms of treatment, sometimes I don't even use the steroids because it suppresses the abscopal effects. So as minimal as steroids is the dictum what I follow now. Thank you for your patience hearing.